So why we get started. So before we get started, just wanted to say, so for these lectures, that now that we're restarting the lecture series for the next academic year, Mona, Bas, and Alex have been doing a great job organizing these. But I do think that it's important that we try to start these on time. So basically, every Thursday at 2 p.m. East African time, we really need to have everyone here on time and ready for the lecture because, with people logging on from the US, I mean, here for me now it's 7 a.m. So, I'm here instead of being at morning rounds. And, people often immediately after giving the lecture have to start doing procedures, etc. So I can't really stay longer than 8 o'clock here, so which is 40 minutes from now. So going forward, if Alex and one of us, if you can really try to remind people on Thursdays to be available on time. And I know that it's sometimes difficult when there's procedures going on, etc. But on Thursdays, you just really need to try to plan accordingly so that we have everyone available for the lecture. Does that make sense?
Yes, boss. We'll do that.
Yeah.
Great. Because, this is like your 1 hour of lecture per week, right? And this, throughout the year, this really covers, pretty much everything you're supposed to know for your exams at the end of the year. And you guys can also guide this, right? So if there's particular topics that you guys want to learn more about, you just tell Alex and Mona Bas, and they can plan accordingly. I mean, so far we've only drafted the schedule until the end of the year. So the entire, January onwards is still open. So you guys can also influence who you want to invite, what topics you want to cover, etc. And like what we try to encourage all speakers to do is to really make those presentations interactive, right? So you guys can chime in and really try to learn. All right, but let's just start off here. Share my screen. You guys can see this?
Yes, we can.
Perfect. Good. So I'll just do a little introduction, and we can make it. We'll talk a little bit about sort of IR background stuff, and then I'm just going to show some cases, and do it almost like a board review. All right. Sorry, I have like a cold. All right. So I see that Charles is also on the call. Hello, Charles.
Sorry.
How are you?
Hi, Fabian. Hi, Fabian. And hi, the team.
So for anyone who hasn't met him, this is Charles Hanika, our very good friend and mentor from South Africa. And I mentioned this because Charles was actually just with me in Munich a few weeks ago. So this is my hometown here, and Charles and I actually walked along this street and along this building. So I'm from Munich, which is in southern Germany, and I bring this up because I just wanted to tell you a little bit about my path into interventional radiology. So this is where I went to med school. This year actually is the library where I studied for all of my exams. And throughout med school, I was always thinking about going into orthopedic surgery or neurosurgery. Those were really sort of the main fields that I considered. But then during my last year or my second last year of medical school, I went to the United States for about 10 months, and I did research at Yale. And the research happened to involve some radiology research. I mean, technically I was in the department of biochemistry, but one of the projects I collaborated with a radiology researcher and worked on some MRI research. So this year's me like in the Yale library at the time. This is now a little bit over 10 years ago. This was in 2013. So then I returned to Germany and I started off my final year of medical school with a little road trip. So I took off 3 months, and myself and two other friends drove from Germany all the way through the Middle East to Mongolia. And from Mongolia, we took a train down to China. From China, we took a boat to Japan. So this took us about 12 weeks to get to Japan. Here's just like a few pictures from along the road. We really, had a great time. Got to explore a lot of different places. So, but then I ended up in Japan. I did 4 months of internal medicine. I already knew that I wasn't going to go into internal medicine. As I said, I was most interested in surgical fields. But of course, Japan is beautiful, and I had a great time. I then did 4 months of surgery in Samoa. So it's really, learned a lot about surgery, and I was always very interested. But then I spent 4 months in the US doing radiology. And so when I set up these rotations, I was really thinking about diagnostic radiology. But then when I arrived for my first rotation in the US, which was in New York, they happened to put me on interventional radiology. So I'd never heard about IR at that point. And I was like, I had really no idea what it even is. and mind you, this is really during the last few months of medical school. And as soon as they put me on IR, like from the first day, I was just absolutely amazed. I'd never seen anything like it, and I was really fascinated. So it was then that I knew immediately, all right, this is the field I want to work in. And what this goes to show you is that, often in medicine, it's these like little coincidences, right? So you just have to have an open mind. You have to try to learn as much as you can. You have to try to see as many different fields as you can see, and really to really figure out what you want to do. And IR is such a broad field. And that's why I really want all of you trainees to try to learn as much as you can from all of the visiting faculty that you have, from all of the lectures that you have, because there may be areas within IR that you're not even aware of yet, and that you may feel really passionately about. So now coming to IR. So the way IR training works in the US is you do medical school, you do an intern year, either a surgical or a transitional intern year. You then do 3 years of diagnostic radiology, followed by 2 years of interventional radiology. And this training model is really, we essentially copied this for the programs in Tanzania and in Uganda, right? So you all completed your diagnostic radiology training. Most of you probably did 3 or 4 years. And then after that, you do 2 years of interventional radiology. And the prior training model in the US until about 5 years ago was that you do 4 years of diagnostic radiology and you only do 1 year of interventional radiology. But then the decision was made to change this training model, because interventional radiology has been growing so much over the past few decades that you really cannot cover all of IR in only 1 year. So that's why we felt also that for these training programs in Dar and Kampala, we need to do 2 years of IR. Great. So now let's come to what is interventional radiology, right? It's a little bit hard to define, and people always joke about that. Even their parents don't understand what IR is, but it's kind of true. It's a little hard to explain, but what I usually say is that it's a mix of surgery and radiology, right? So we're kind of combining the best of both worlds, and we're using image guidance to make procedures less invasive, thereby causing less pain and being less traumatic, and allowing for shorter hospital stays. With this, also we can allow for less need for general anesthesia, right? So we can do about 90% of our procedures just under moderate sedation, or sometimes even just under local anesthetic. And all of this combined really leads to lower complication rates and can actually lower costs, right? Well, in IR, often the upfront investment to build an IR department are quite high, because you need all of the specialized equipment. At the end of the day, by having shorter hospital stays, by having lower complication rates, by getting people home earlier, you can actually lower the overall costs to the healthcare system. Another thing that I really love about IR is that we really work with everyone in the hospital. And, Aza, Eva, everyone who's been doing this for a little while now, you notice this, right? So we can really collaborate with essentially any department in the hospital, and most of them we can offer them something, right? So this is really the beauty of IR. Now, what makes an interventional radiologist? To be a good IR, you of course need to have a really good knowledge of anatomy, vascular and non-vascular. You need to know all of the tools that we use in IR, and we're going to talk a little bit about that today. And on that note, by the way, this is ever changing, right? So you in IR you really never stop learning. There's always every year there's new devices that come out, new techniques, new tools. You need to always keep an open mindset and be willing to learn about new things. You of course need to be an imaging expert, all right? This is why we do 3 to 4 years of diagnostic radiology training before we start training in interventional radiology. And then last but not least, you need the technical skills. So that's what we do the final 2 years of hands-on training to learn all of the hands-on skills that you need. Now, in terms of imaging modalities, you guys, of course, know all of these. So we use a combination of them, CT, ultrasound, fluoroscopy, and in some cases, MRI. But, I think really the most commons are those three. So fluoroscopy, ultrasound, and CT. And in many cases, actually, we use a combination of those, right? There are some countries where IR is kind of split up by modality, especially in China, from what I've learned. So in China, you have IRs that do only CT-guided procedures, or they do only ultrasound-guided procedures, or only fluoroscopy-guided procedures. And I think there's some advantages and disadvantages to that, but I personally, what I like about IR is that you can to have the flexibility to use different imaging modalities depending on how you want to approach the case, what the patient is like, etc. So I personally much prefer the model where every interventional radiologist should know how to learn all of the different imaging modalities and not really restrict themselves to just one of them. All right, so here we can talk about a few tools, starting off with the very basic tools. So this here is, of course, a biopsy gun, and I'm sure even the new trainees have seen that by now. What's special about this one, and this is like a BART biopsy gun, it comes with, you always have a guiding cannula, and it comes with a sharp inner stylet, and it comes with a blunt inner stylet. Asa, do you know those biopsy guns that you guys are getting now? Do they have this blunt needle included? Or someone
No, they
else?
don't.
They don't. Okay. So eventually, if you guys can find some that have these at least for some difficult cases, I think it can be very, very helpful. I'll show you guys a case later that kind of demonstrates that. But if you guys are around shopping for biopsy kits, if you find one that has a blunt in a needle included, I think it can be very helpful. Good. Then over here, drainage catheter, right? Pretty standard. What we can also talk about here is just how to measure things, right? So for the new trainees, needles we typically measure in gauge, all right? And the smaller the gauge, the bigger the needle. A typical biopsy gun, we use 18 gauge, but of course you can use bigger. You can use 16 gauge in some cases. When you're doing a breast biopsy, often we're doing like 12 or 11 gauge, all right, which is much larger than 18 gauge. In terms of catheter sizes, we use the French sizing, all right? So a typical standard abscess drainage catheter would be 10 French. 1 French is 1/3 of a millimeter, right? So 3 French is 1 millimeter, meaning a 10 French drain is about 3.3 millimeters in size, all right, in diameter. Now coming to different types of access needles, Himidi, why don't you tell me about what needles you see here and which ones you know? You have to unmute. I can't hear.
So we could group them into vascular and non-vascular access needles.
Okay. So what is this here, for instance?
That's a vascular access needle with a
Okay.
guide wire, and then
So yeah, so we call this a micropuncture. So I don't think I would like really divide into vascular and non-vascular, because you know you can use anything for whatever you need to, you know, whether it's vascular or non-vascular. But this is a micropuncture. What size is a micropuncture typically? What size is this needle?
So, I think 21 and 22 needles.
21. Okay, so let's say 21. So what size wire can you fit through a 21 gauge needle?
an 038, 018.
018, exactly. And 018, like how is that measured? 018 what?
Okay, inch. They come in inch.
Inches, exactly. Good. And then so this micropuncture kit then comes with these two things, right? Why does it have two? Why do you have two? What's the point of that? And what size are they typically?
Those
This is
are
the inner. Go ahead.
those are transition dilators. Both
Exactly.
the inner and the outer. The outer is 5 French. I think the inner is 3. I'm not quite sure now.
Yeah, exactly. And so you have these two, right? You have the 3 French goes into the 5 French, so that you have like a smooth transition here at the tip. And then you can slide this in over the micro wire. Then you take the micro wire and the inner 3 French out, and then you can go with a bigger wire. What size do we typically use for like our larger wires?
Yeah, 035.
035, exactly. Good. Then this needle over here is called a Chiba needle. All right. So again, you have like a little similar to the biopsy gun. You have an inner needle and then sort of an outer cannula. There's different sizes and shapes for these, of course. This is a trocar needle, and then this down here is an AccuStick set or NAF set, I think in this case. But you know, there's different variations of these, but it's essentially a triaxial dilator system. So you have an inner metal stiffener, you have sort of an in-between plastic dilator. Again, this is typically 3 French, and then you have the larger outer catheter. And again, this can be helpful for if you need to access something with a small needle. You have an 018 wire in, then you can get this triaxial dilator and you can upsize to an 035 wire. In terms of wires, of course, there's many different sizes and shapes. This here just shows like a J-tip wire. We have hydrophilic wires, non-hydrophilic wires. So depending on what organ system you're working in, where you need to get to, what type of catheter you have, you can use different types of wires. Seldinger technique. Good. So here, why don't we have Agbola? If you're there, can you just explain to our incoming junior trainees what exactly the Seldinger technique is and how it works?
This is using a needle to access into the vessel. So Seldinger technique basically is when we use our needle to get into the one wall puncture. And once we do that, we put in our wire to secure our access. Then subsequently we can transition from the needle to the transition dilator.
Exactly. And the point here is that you never give up your access, right? And this is a very important principle in IR is like you always just exchange things, right? Until, of course, when you're done with the procedure and then you give up your access. But you're getting access with the needle. As you said, you put in a wire, you slide out the needle, you insert the catheter over the wire, and then through the catheter you can work, right? So you can put in a sheath. Through the sheath you put another catheter. Through the catheter you sometimes put an even smaller catheter. Through that you put a wire, right? Or or sometimes even more layers. All right, now how do you size a sheath, Sam? How do we measure sheath sizing?
A sheath is measured in French, but the measurement is the inner diameter, not the outer diameter.
And in a typical, so, you know, like a common sheath size that we use for vascular procedures is 6 French, right? So what's the outer diameter of a typical 6 French sheath?
So the outer diameter is usually like 1.5 to 2 French larger.
Exactly. And exactly, as you said, so 1.5, and there's some, you know, for instance, when you're doing like radial access, we use these slim sheets, and they're only 1 French larger on the outside than inside. So then if you're using a 6 French slim or slender radial sheath, it's only 7 French on the outside. Great. Over here, we have a few dilators. And then here we have different types of catheters. Again, you know, there's a really broad range, but just to go through a few important ones, this here is a pigtail catheter. You can use this if you really need to achieve high flow rates, for instance, for an aortogram. This is an omniflush catheter, straight flush catheter, Sauce, Mickelson, Rim, Simmons, right? So these are all like reverse curve catheters. We use these to get into celiac trunk, SMA, renal arteries, IMA. So you can see here how you can hook into the artery. These are different types of Cobra, 1, 2, 3. This here is a Bernstein or Campi catheter, right? So this is really the most commonly used catheters of all. And here you can see how there's sort of multiple layers of catheters and wires within other catheters. In terms of embolic materials, again, there's a whole range, starting here with gel foam. So this is just like a gelatin sponge. You can cut it up, mix it up, inject it to embolize. There's different types of coils. What we're seeing here are fibered coils, right? So you can see it's a coil and has the stuff hanging off, which helps with clotting off whatever vessel you're trying to occlude. And you can see here how the coils are delivered. So typically you just hook up, they either come in like a little needle or in sometimes like a little plastic tubing. You kind of just hold that to the end of your catheter, and then you use a pusher to push the coil through. Here it's just showing how the coil is sort of deployed. This here is a plug, an Amplatz vascular plug. Again, there's different varieties, sizes, and shapes, but they can be very helpful, and it can sometimes be quicker than putting in a bunch of coils, especially if you're working in a larger vessel where you don't want to have to deploy, you know, dozens of coils. You just put one plug in and be done with it. And then over here we see some particles, right? So these are called embospheres. Again, they come in different sizes, and they can be used for different types of embolizations, like uterine fibroid embolization, prostate artery embolization, etc. And then here, if we don't want to close a vessel down, but we want to open it up, we can use balloons and stents. All right, so here you see a balloon. This here is a balloon-mounted stent. So this is a stent that you insufflate the balloon, and then the stent essentially sticks to the wall. This here is a self-expanding stent. All right, so these self-expanding stents, they essentially come loaded in a sheath, and then you unsheath them. So you just pull this back, and the stent then opens up. All right. Good. So then why don't we look at a few cases here? So who do we start with? Maybe Alex. Why don't you walk me through like a very basic IR procedure? So you have a 65-year-old female here presenting with right upper quadrant pain for a surgical candidate. Obviously, there's concern for cholecystitis. So how do you go about this procedure?
Okay. So yeah, a 65-year-old female with a right upper quadrant pain with a surgical candidate with a cholecystitis. Can you hear me? Hello?
Yes. So
Okay.
what do you do to treat her?
So with this patient would require a cholecystostomy drain.
Mm-hmm.
So there are two approaches for this patient. You can either use a hepatic route or transperitoneal route. I would use the transhepatic route for this patient because it anchors the tube better than the transperitoneal, and also it forms a better fistula. So for this patient, using ultrasound guidance and fluoro, I would use a Seldinger technique. Put my micro access needle into the gallbladder, and then send the micro wire through it, the 018 wire, and then transition with a transition sheath, 5 French or 4 French, and then place in. From that point, you can either inject contrast to see if there's which kind of obstruction is that the cystic duct, or you can do it when you're finally placing your cholecystostomy drain. However, I'll then send in a working wire, maybe an unplugged wire, and use that to put in my multi-purpose drain tube and suture it at the skin. Then maybe if I hadn't done the cholecystogram, then I would do it at this point.
Exactly. But sometimes you have to be a little bit careful. You don't want to stir things up too much, right? So if things are really infected, like you inject a little bit to confirm, but you don't want to over pressurize the system, right? Because the more pressure you put on things, there's higher risk of bacteria sort of transgressing into the bloodstream and the patient getting septic. The same applies to when you do biliary drain placement, like often or nephrostomy placement in the setting of infected patients. Often when you're doing the initial placement, you want to be a little bit gentle. You do inject contrast to confirm where you are, but you don't want to go overboard and have them get septic.
Yeah.
Great job. Good. So now we have a 30-year-old female with mid-abdominal pain. Eva, what do you see here?
Sorry, I was unmuted. As muted. There's a enhancing lesion within the mesenteric city. It's hypothetical with ultrasound, no vascularity, and capsular application.
Great. So then how would you go about biopsying this?
I'm looking for a separate and thin bowel around the lesion on CT. So,
Do you know any tricks how you can kind of displace bowel or get around bowel safely?
yeah, changing posture.
Say again?
Sometimes repositioning the patient helps, but I'm not sure how it would help in this.
That's great. So there's a few different things you can do. Different positioning definitely can be very helpful sometimes, especially when you're trying to biopsy something on the sides, you have bowel in the way. Sometimes you just roll the patient over to one side and the bowel kind of just moves out of the way. Here, that would probably be difficult, but there's a few other things that you can do. So first of all, sometimes you can just displace bowel with pressure. All right. So sometimes if you're using ultrasound, you can see here I'm pushing with a probe, and you're actually pushing a lot of bowel out of the way. And here, one of my colleagues here, Doug, he actually developed this little. It's like a bowl, kind of just looks like a bowl you would use for soup, and you cut a hole at the bottom, and you can then strap that onto the patient and really exert a lot of pressure on it, and then it displaces the bowel, and you can do your biopsy through that hole in the bowl. All right. Another thing you can do is you can get access and can do hydrodissection, right? So sometimes you just infuse some fluid and you can displace things. But then what the reason why I brought up earlier this biopsy gun with the blunt needle is you can also just use a blunt needle and you can push yourself in between bowel loops, right? So here you got access over here with a sharp needle, then switch to the blunt tip and just kind of push in between the bowel loops using a combination of CT and ultrasound guidance until you're by the lesion. And then once you're at the lesion, you switch back to the sharp needle, you push into the lesion, and then you can do your biopsy, and that's it, right? So that's why it's really nice having these blunt inner needles, because you can really avoid causing damage to surrounding structures. I also like using them, for instance, if I do like a transgluteal drainage of some deep pelvic drain, you know, because sometimes you have like a really sort of like a perirectal vascular plexus. And, you know, then I use the sharp needle to get through the gluteal muscle. I switch to the blunt needle to get through the vessels. And then I switch back to the sharp needle once I'm in front of the abscess to enter it. All right. Then, bam. Where I take this? 52-year-old male with hypertension after paracentesis. What are your thoughts?
Sorry, did you mention anyone specific? I didn't get that.
Oh, you take it.
Okay, so 52-year-old male with hypotension after paracentesis.
Mm-hmm. So what are you concerned about?
Okay, so so this patient probably had presented with a history of abdominal distension and pain. So probably after investigation, maybe on CT or ultrasound, was found to have ascites, in which the plan was to do paracentesis. However, in which the guideline, we are supposed not to drain more than 5 liters, because if you drain more than that, you need to replace it with albumin, 6 to 80 grams per liter of albumin.
Okay. And now let's say they get the patient comes back, they get some labs, and platelet count is 80,000 and hemoglobin is 6 from a prior baseline of 11.
A paracentesis is usually, according to SIR, regarded as a low bleeding procedure. So platelet and INR is not routinely recommended. So we might have proceed with the procedure.
Okay, but this is now already, this patient already had a paracentesis done by a general doctor without image guidance.
Okay, so probably we, as from IR, we would need to intervene, and maybe we can put a drain, or if this patient has some sort of recurring paracentesis, we may try to do what's known as, is it the Denver catheter?
Now you see this imaging.
Okay, so it's a CT, contrasted axial view at the level of the pelvis. There's obvious ascites that is displacing bowels centrally. However, there's like a foci of hyperdensity on the right lower quadrant. Maybe suspicions of bleeding.
Exactly. What do you call this here when you have a hematoma here?
Peritoneum secondary to paracentesis.
Yeah, I mean, some of it may be going into the peritoneal cavity, but most of it, when it's sort of in this shape, it's called a rectus sheath hematoma. All right, so it's in the rectus sheath. All right, but you see, as you said, there's bleeding here. All right, so now what do you do?
Okay, so probably now the cause could be we've injured most likely the inferior epigastric artery. So this patient, we will also first of all need to assess his or her clinical status, in which resuscitation may be needed. And if we think the patient is stable and may be able to tolerate undergoing CTA, we may do, but otherwise we may need to go straight to angio and do arteriogram and identify the source of bleeder and probably do coil embolization.
Exactly. And then, so how do you do your angiogram? Where do you get access?
Okay,
what do you plan to do?
So the access should be on the femoral, using the Seldinger technique, accessing the femoral artery at the level of the femoral head, where after the access, we will put a micro wire and then put a sheath. And
and on which side? On which side?
Ipsilateral.
Okay. So when you access the common femoral artery,
Yes.
What's the definition of the common femoral artery? Where does the common femoral artery start and stop?
Okay, so the common femoral artery starts below the inguinal ligament after the external iliac has given off the inferior epigastric artery, which usually runs medially and goes obliquely upward.
Exactly. So then, when you're doing ipsilateral, it can be very difficult to get in there because you have no room, right?
Okay.
So typically, if you try to get into the inferior epigastric, you go on the contralateral side, all right? So that you have some room to work with, because you can imagine, I mean, you can see it here, right? So this here is the inferior epigastric.
Okay.
Right. So
yes.
if you enter on the same side, it's very difficult because you have like no room to work with. You would have to enter like very low down, and it would be like very difficult, unstable access to try to get in here. So often what we do for these is we come in contralateral and we go up and over. All right. So in this case now, there's a long sheath. You see it's a Balkan sheath that goes up and over, 6 French sheath. And through this, there's a 5 French catheter, which is now selecting the inferior epigastric artery. All right, so then you inject some contrast, and now you see this. So what do you do?
After injecting the contrast, we expect to see some extravasation through the injured vessel. And after super selective the inferior epigastric artery, and that's when we can do coil embolization, I think.
Yeah. Okay. And from where do you coil? Do you try to coil in here? Do you just try to coil the inflow? Do you try to coil from here? What do you want to do?
I'm not sure, but I'm gonna try. So maybe we are going to coil from distal to proximal. Not sure.
Yeah, no, exactly. So if you can, and I mean the reason being that you in some cases you can have collateral inflow from elsewhere, right? There could be collateral inflow from the superior epigastric. So if you can, you have a vascular injury like this, you try to get across, and then you coil back. All right. Because if you only coil from here, you can't be certain if then there can be inflow from elsewhere and it can continue bleeding.
No.
So in this case now you can see here the micro. It's a little hard to see, but there's a microcatheter that's across here, and then we kind of just coiled back across the lesion. Once you've done that, you can inject here, and you can confirm, okay, there's no longer any bleeding.
Thank you for that.
Great. Then maybe Sam, do you want to take this?
Yes, 70-year-old man with history of smoking, presenting with head and neck swelling. Given this history, I'm thinking of a possible lung malignancy probably causing superior vena cava obstruction. So in the CT image, I can see a mediastinal mass, which is, it appears to be encroaching on the superior vena cava, completely surrounding and narrowing the lumen of the superior vena cava.
Okay. And would that explain the symptoms that the patient is presenting with?
Yes, it would, because I think we are dealing with a superior vena cava syndrome where the engorgement of the superior vena cava due to obstruction is causing blockage of the venous return.
Yeah, exactly. So then what do you do to treat this?
These patients, I think they need, for diagnosis, you'd need to get a biopsy to confirm the tumor. But then the superior vena cava obstruction, you need access so that you can be able to drain the neck drainage using a micro.
Okay.
Using a micro access through the internal jugular vein. Use a micro access and then transition a micro wire and then transition to a 5 French and see if I can get my wire down to the right ventricle. So
exactly.
in this
or even
image,
further down. You know, ideally, when you're working through like IJ access, especially when you're using like bigger catheters and sheaths, it's usually best to really try to get your wire down all the way into the IVC. All right, and you put a stiff wire,
the wire
like an
should go
Amplatz wire.
down up to the IVC, and then you can replace your drainage catheter over the 035 wire if you manage to go through.
Yeah. So in this case now, you know, what you want to do is you get a sheath in here, you map things out, and then, you know, you want to try to relieve this obstruction. All right. So you can start off with just using a balloon. So, you know, you would use a large balloon here, probably like 10, 12, 14 millimeters. All right. You just try to open this up. But, you know, when you have a malignant obstruction, typically just angioplasty alone is not going to deal with it, right? Because it's just going to close right down. So then what you do is you deploy a stent. All right. So that's what we did here. So then you just deploy a stent, and then the head and neck swelling resolves typically within a few days. All right. So it's very, very, very quick and helpful procedures for these patients. I think we're going to wrap up here because we have to join a call with Dr. Prologo, who's coming to Tanzania in a few weeks, and to discuss planning with him. In Uganda, Eva, you guys have been in touch with Miriam, right? And Mark.
Yes.
Any updates there or anything in terms of equipment or planned cases?
No, nothing specific.
Okay, but everyone should be all set.
Yeah.
All right, very good. Okay, I'm gonna have to hop off. But then I have like a lot of other cases I can show. So, you know, we can, whenever there's an open lecture slot, Alex and one of us, just let me know, and then we can finish this.